It's my pleasure to welcome all of you as the President to the College of Surgeons Sessions 2023. And for the first preliminary lecture, we have got Professor Neil Mortensen, who is also the chief guest. Proper citation and the introduction will be done in the evening, but just to give a very short reference to what he has done, he is the Professor of Colorectal Surgery in the University of Oxford Medical School and has been on the staff of the Oxford University Hospital since 1987. Actually, he is my guru who taught me coloproctology when I was in the UK. He is past chair of the British Journal of Surgery Society, past president of the Ileostomy Association, and has been the past president of the Association of Coloproctology of Great Britain and Ireland, and the coloproctology section of the Royal Society of Medicine. He is immediate past editor-in-chief of colorectal disease. He is an honorary member of a number of national and international surgical societies, including the American College of Surgeons and the American Surgical Association. He became a member of the Council of the Royal College of Surgeons of England in 2013 and a member of the Trustee Board in 2016. In 2017, he was appointed Vice President of the College of Surgeons of England, and in 2020 as the President. So let me invite Professor Neil Mortensen, sir, to deliver your lecture.
Well, good morning, everybody. It's lovely to be here. It's a great honor to have been invited. Thank you so much for inviting me here. As you've heard, I met Sam 30 years ago nearly. We were both very young then. It's great to come back, and it's great to hear about the progress that surgery's made in Colombo and Sri Lanka more generally. Just make this work. We just get my, that's good, okay. So, greetings from Oxford. I haven't really been there very much recently. As you heard, I became president of the College of Surgeons in London in 2020, just as the pandemic struck. Spent quite a lot of time, as many as you did, in front of laptops or devices during the pandemic, and then a lot of time up in London, and I actually demitted in July. So I'm just going to make a few reflections around surgical training, because this is partly the theme of your conference. A few disclosures: I'm not a professional educationalist. I do have a lifelong passion for teaching, training, and developing the surgeons of the future. Everything I'm about to say is completely my own view. And the bedrock of everything we talk about at a meeting like this is, of course, not only our own professional development, but particularly about our patients and better outcomes. And clearly there's going to be a bit more of a UK perspective. So why did I use avatar in the title of the talk? I suppose it's to get over the idea of the trainee surgeon of the future being a digital trainee. You've seen the film, you know about divinity taking a human form, but this is about digital representation, which is going to become a huge issue, I think. So, as I've said, we didn't see the pandemic coming, but it's had a revolutionary effect on all our thinking, I propose. Suddenly, we have the COVID dividend, the rapid development of remote working by Teams and Zoom, which improved almost month by month as I was engaged in some of the meetings in the UK. We got very, very quickly used to remote learning and tutoring, to running our MDTs remotely. This has truly, I think, been a digital revolution in our training and our understanding of how we teach and learn. But of course, for our trainees, there was collateral damage, lots and lots of training opportunities lost. These are the data from the UK. 1.25 million fewer elective operations performed, and therefore a massive reduction in the number of training opportunities. So this made people begin to think a little bit about how can you train surgeons in the future? How can we train ourselves in the future if we can't actually be there? 3 elements of surgical learning, of course, are knowledge, which we can often do remotely, though not completely well. Technical skills, maybe we can simulate well enough, but mostly we need to be there. And then there are the non-technical skills or human factors, which we actually have to be around people to see and learn in practice, but we can also learn in theory. There's also been another COVID dividend, which I think is more difficult to describe, and maybe this is true in your surgical community too. A feeling that maybe there is more to life than just surgery, a feeling around reducing working hours, work-life balance, and therefore being in the room all the time to get that training and teaching is a problem. There have been some proposed, what I would call imperfect solutions. We can train for longer. In one sense, as I'll say at the end, we are in lifelong learning in any case. We can have a narrower portfolio, i.e. super specialize. We can have credentialing for complexity only when you've done the course or been mentored in the operation are you allowed to do it. That's beginning to happen progressively. And then we can look at simulation and virtual worlds too. All this is happening simultaneously with a massive change in the environment in which surgery is delivered, how it's funded, the rapid advance of technology, and the progressively tough regulatory environment. Now, I think it's very easy for somebody like me, although we have many problems in the UK with our health system, we are a wealthy country. It's very easy for me to completely ignore what's happening globally in the world. And I just wanted to mention this initiative that we have with the London School of Economics. The Lancet Commission on Global Surgery in 2015 suggested there were around 5 billion people who were lacking access to safe, affordable surgical care, and 11% of the world's burden of disease is surgically correctable. Yet most of what World Health Organization arrangements devolve or revolve around are medical problems. So our global surgery policy unit established with the London School of Economics is going to be slightly different. It's not going to be us going out and providing surgery. We are going to, we hope, with the expertise of the London School of Economics, be the advocates globally for a bigger slice of the health cake in nations around the world devoted to surgical care. And there are various ways of doing that, but in essence, it's all about advocating for surgery globally. So, although it was happening before COVID, this has all accelerated rapidly. The ways we learn have changed out of all recognition. You only just have to search YouTube to find an operation and copy it. See one, do one, teach one, perhaps. The problem is it's not always regulated or indeed curated. When I was editor-in-chief of colorectal disease, we came up with a policy or plan around surgical videos. And we decided that we would curate every video that was sent in, and we had actually appointed video editors. We suggested that the form should be around 6 minutes because attention span isn't much longer than that. And now we have over 10,000 videos on the colorectal surgery YouTube channel over a huge range of subjects, and it provides the most amazing teaching training resource. That's just happened in the last 10 years, just like that. And of course, all the colleges are doing webinars, podcasts, remote learning, and there's been the development of channels like Advances in Surgery 2, which are a global phenomenon, and any of us can get access to that for teaching and training any time of the day or night. Hand in hand with that comes social media, which is also, I think, creating a massive revolution in teaching and training. We can do remote mentorship. We can help people with a WhatsApp group. We can help with their networking. We can help with their identity. We can help with marketing, branding, public communication, even communication directly with patients. And we can recruit for research using social media too. A massive, massive change in the way we do things. But there's a downside, isn't there? There's an issue around patient confidentiality, an issue of self-promotion. Although it's important that people know we're good surgeons, what's the balance between being a cowboy and being an honest professional? We have to be sure about maintaining boundaries and being careful about inappropriate relationships. And of course, social media can be destructive and disrespectful. So let's go back to the good old days. Here we are, Henry VIII and the Charter to the Barbers and the Company of Surgeons, 1542. Back then, it was all about apprenticeship training. You attached yourself to a master, and you basically watched what they did and tried to copy it. You would then obviously go on and add to your portfolio of experience by traveling around Europe or going to see other master surgeons. And at that time, there were primitive assessment arrangements based on you've done an apprenticeship with so-and-so, therefore you must be okay. I guess the modern version of that would be fellowships and expert centers. We have our ISTP program. I know Sam spoke to me about it, and I think all the colleges help with the medical training initiative in the UK. So there are people who are questioning the apprenticeship model. If you're with a bad master surgeon, of course, you could have a bad experience. And this is a suggestion of the different ways in which or how we learn surgery. I personally don't think any of these are exclusive. There is still a place for a particular procedure of a single mentee and a single mentor. Clearly, that's how we learn new complex procedures. When we're thinking about doing surgery, there will be many of us competing for our surgical places in the surgical hierarchy under a single mentor. Halstead, when he set up the idea of surgical training programs, suggested there should be multiple mentees who would progress to graduated autonomy under a single mentor. And then, of course, the modern, if you like, idea is that you have multiple mentors for each mentee. But then, of course, who is responsible for that teaching and training? The big digital revolution is, do you need to be in the room for that training? And the avatar surgeon of the future is not in the room. And is that a good thing or a bad thing? And how can we make it the best it possibly can be? I was really, really impressed when I was doing the rounds in the UK with the urology boot camp. In the second year of urology training, every UK urology trainee goes to the boot camp and they get exposed to a whole range of simulations of the various aspects of urology. It was absolutely brilliant. Some of the simulation was very complex, some was very, very simple, but it all seemed to work extremely well. And so they then go back to their hospitals, and if they're confronted with something for the first time, it's not a surprise. They understand the problem, they have an idea of how to manage it, and it becomes something that they feel comfortable about because they've had that surgical simulation. We'll say a little bit about augmented reality and AI later. Now, many of us would like to see this happen. The Holy Grail is, you are absolutely brilliant, you've been trained up in your simulation system, and you are completely capable of doing the operation before you even touch a patient. That's the Holy Grail. And some of the platforms now, like the robotic platforms, are beginning to give that hope that we might have individualized imaging-centered rehearsals of a procedure we might do the next day. There's lots of talk about it. It's very exciting. We're not quite there yet, but the potential is enormous. Now, this is me in a flight simulator. It is a Hercules transport plane, and I'm at the controls on the right side of the picture, and I'm flying under the Tower of London. You wouldn't normally be allowed to do that, of course. And many say the idea about flight simulation is that, again, it puts you in the position where you can get in the plane and fly, and you know what to do. And everybody says, well, why can't we just do that with surgery too? It's a huge investment. It's highly technical. You can learn human factors as part of it, stress situations, etc. Obviously, pilots have mandated refreshers, and we have never, ever had the investment in surgical training to allow that to happen. It's actually much easier to have the old Apprentice model, much cheaper, and that kind of investment has never, ever happened. But I think with robotic platforms, there is the promise that this idea of the parallel with flight simulation might actually happen. This is a paper from 2015, and I'm just going to read it out because it's the kind of hyperbolic language that people use when they talk about patient simulation. Immersive patient simulators allow an illusory immersion into a synthetic world where the user can freely navigate through a three-dimensional environment similar to computer games. Playful learning with the immersive patient simulator allows internalization of medical workflows without harming real patients. Now, of course, we have simple simulators as patients, but the kind of complex simulation we need in surgery is still, unfortunately, miles away. Now, this is a picture of me as president, and we have a historic Da Vinci robot, not one of the latest ones now, in the entrance hall of the College of Surgeons. I wanted it to be there as a symbol of the future of surgery. Many, many surgeons will, of course, say around a particular robotic procedure, what's the evidence that it's really any better than laparoscopic? What's the evidence that it's really any better than open surgery? It's quite interesting. Obviously, there was the Da Vinci robot around 20 years ago, and it's taken some time to get to the point, get to that inflection point, get to that point where it suddenly seems to be there, and now we're talking about it in many, many specialties, particularly urology, clearly, and in my specialty, colorectal surgery. It is, I'm absolutely convinced, the future, and all of us in 20 years' time are going to be using robots of one kind or another. I recently visited, about 16 months ago, an absolutely brilliant training center in Ghent in Belgium. It's called Orsi. If you've never had a chance to visit, I suggest you have a look. They've managed to get all the main robotic companies under one roof, some also medical device companies related to interventional radiology. And they have a system which is basically a system of proficiency assessment at each stage of a segmented operation. So you break down a procedure into 10 steps, you do 10 steps. Step 1, you can't do step 2 until you've done step 1 really well. Build up to step 2, 3, 4, 5, and so on. And you can't then go out and use the gear, use the platform, until you've been through all those 10 steps. This, I think, is a model for proper managed surgical training in the future. Progression depends on your proficiency in each of those steps. And of course, this could be the kind of place where we could go back as seniors for our refreshing courses, much like pilots have to mandatorily, and for credentialing around particular highly specific operations. Part of the problem with the robotic revolution is that much of the training is in the hands of the companies. And I think we as a profession are struggling to wrest that from them. We can accredit their training. Both the platform and the team, that is our surgical team, need to be helped. Provide mentors, of course they do, but there's ultimately a conflict of interest, and there is a relationship clearly between training people on a particular robot and sales of that robot, which is one of the things we're struggling around trying to control. Not in a bad way, in a good way, so that the training that happens on a robot is properly accredited and fit for purpose. We do know that if you have proper training for established surgeons, it can make a difference. In the UK, we had this experiment called LAPCO, where we were looking at ourselves and seeing in the UK we were around 20 or 30% only of some colorectal procedures were being done by laparoscopic surgery 15 years ago. LAPCO came along, and we now have, this is just one paper of many in the Annals of Surgery showing that it actually did improve outcomes after a national training program for specialists. So what we've got to see now is that surgical training isn't just the training before we become a staff member. Surgical training clearly has to carry on after that too. One of the things you're going to hear increasingly about, in its early days yet, is the whole idea of entrustable professional activities. First developed in the Netherlands, the American Board of Surgery is adopting this, I think, from now, from the autumn of 2023. This is a way of making sure that surgeons, in our case, can be entrusted with a particular course of action. It's very complicated. You need to divide our work into clear chunks and to be able to say, this person is now absolutely ready to be able to manage, for example, right iliac fossa pain, right from diagnosis and then the surgery and then the management afterwards. Interesting idea, early days, watch out, it's going to come to a college or street near you. Now, part of the problem with all this technology is, how do we decide what's best? We had a very, very lively trainee surgical group who got together and produced this document in 2022, Technology Enhanced Surgical Training, trying to come up with a suggestion or a methodology around how do we decide which of these many training platforms is the best for us. And that's going to partly depend on individual specialist associations, but as colleges too, we have to be sure that we're helping make those good decisions around how's the best way to teach technology-enhanced surgical training. There's much talk around artificial intelligence at the moment, which of course is really two things, machine learning, that's what's mostly happening. Autonomous robotics are a little way away. I think Abby is going to be talking about ChatGTP and so on a bit later in the program. Clearly it's important in drug development, image analysis. You won't need a radiologist for ordinary images very soon. We will need it for optimizing simulation. And I think the most interesting thing about it is every time you use a robot, for example, all those movements you've made can be measured. They can be put into metrics. They can be used to assess how quickly you're learning. And they can also be used to make prompts to help you do the right thing. The brave new world of a robotic platform will be that the robot will suddenly say to you, I wouldn't do that if I were you. The last 1,500 procedures carried out by colleagues of a similar degree of training and so on did step A before step B. Do you really want to do step B first? That kind of informed surgical progress is, again, something that is being talked about now and will happen much, much quicker than we think. We already have another expert in the room, another avatar, and that is Proximi. You may have seen this system where we can have a colleague very, very remote from ourselves. They can be beamed in digitally into the operating theatre, and they can do live coaching and demonstrating whilst we're actually operating. I wouldn't do that if I were you. I would do that. Interesting that the person now who is the trainer or the mentor or the teacher is not in the room. I think part of surgical training also has to clearly include some sort of research. It can be clinical research or it can be laboratory research. It just needs to be part of surgical training, I think, still. Critical thinking, helping us innovate, helping us learn about trials methodology so we have good evidence for what we do, and then helping us build networks. In 2018, the London College produced this Future of Surgery Commission. The great and the good all met. Basically, they put together a vision of what surgery might be like in the future. And the main elements were genomics for personalizing surgery. We're already beginning to do that for some cancer surgery. Clearly, there was a lot of talk about robotics and AI. A big, big emphasis on the way in which we will rely increasingly on a team of people to carry out a particular treatment. All sorts of super tech ideas like stem cells and 3D printing. It did mention a global pandemic, but I don't think it realized quite how bad it was going to be. Just a couple of elements from that Future of Surgery Commission. Minimally invasive surgery in the short term. Clearly, we're all here at a meeting where we're going to be hearing about and talking about developments in both laparoscopic, endoscopic, and robotic surgery. Robotic surgery will become lighter and cheaper, and there are some remarkable new pieces of kit just around the corner. In the long term, it spoke about robotic autonomy. There is something called CyberKnife, which is obviously highly focused radiotherapy, which is effectively an autonomous robot. There aren't really any autonomous robots in surgery yet, apart from, I'm told, in hair transplant surgery. But clearly, robotic autonomy and machine learning will be helping us do our operations better in the future, and those other things there, we hope will reduce surgical variation, the invasiveness of surgery, and maybe we'll need more and more surgical technicians to help us do the job. The conclusions from that commission were also these around surgical training. Curricula need to be more flexible. Many of us will not just be surgeons in the future. We'll be surgeons and a scientist, surgeons and an entrepreneur, surgeon and educator, surgeon and innovator, surgeon and manager. Because of the huge influx of technological change into surgery, they were suggesting, I'm not quite so sure, that surgical medical training had to include elements of computing engineering, molecular biology, data literacy, leadership, team building, and communication. We'll come to the end to describe how on earth we're going to manage all this. I thought this was an interesting point. Need to ensure and enhance humanity in surgery against a backdrop of technology. I mentioned right at the beginning, we're doing this to improve patient outcomes. We mustn't forget the humanity in amongst the technology. I mentioned data analytics helping us find out how well we're doing, and then a more diverse entry to medical schools for a wider skill set. Now, if you look really carefully at why surgeons get into trouble, it's often not just around technical issues. It's often not around technical issues at all. It's often around non-technical skills or human factors. And this, again, we now recognize is a really, really important part of our surgical training too. How we make good decisions, how we manage to communicate with our team, how we personally keep in shape to do an incredibly exacting job. These are all things that are part of what makes us a good surgeon. This is from a recent American College of Surgeons publication, And this is, they were suggesting, the kind of profile that the surgeon of the future should have. I'm going to read it out. It's almost like a saintly wish list. Coachable, self-critical, professional, efficient, knowledgeable, honest, communicative, well-rested, and inquisitive. Pretty difficult to get all those things under one hat. Is this really achievable? Great interpersonal skills, great cognitive skills, great technical skills, and great personal skills. This is the challenge. When I first looked at the idea of avatar in the title, a blessing coming down from heaven in human form, I thought of the surgical trainees of the future. Although we were worried about surgical recruitment in the UK a little while back, it's improved, but still we have an uphill job. Surgery is seen as something that's pretty tough. It's not very family friendly. It's pretty demanding. I personally have enjoyed every moment of it, but what's being asked of the surgeons of the future is more and more, and it's difficult to see how there's going to be either enough time or energy to do it all. One of the inevitable effects of technological change like this, I think, is that there will be super specialization to a degree. Surgeons won't be general surgeons apart from in remote and rural areas. Surgeons will have a narrow portfolio in order to be able to manage all these things under one hat. So thank you again for inviting me to Sri Lanka as your guest. It's a great pleasure and honor to be here. And finally, it's lifelong learning, isn't it? I'm still learning. I think all of us have to recognize that we don't train and forget. We train and carry on. Thank you very much.
Thank you, Neil, for that brilliant presentation. And actually, in your lecture, you said something about shorter training time for the trainees. I think Sri Lanka probably is ahead of you then, because trainees get only 2.5 weeks personal leave during their 3-year training until they sit the exam. But maternity leave and sick leave are excluded. Still, they have to repeat that before they sit the examination. So, and some of the units are on call almost every day, 24/7. But if there are 2, then they will be every other day on call. So cutting-wise, I think they're quite good and decision-making. And that's why probably the UK is employing our trainees. And there's one already in the audience, Michael Silva. And probably more and more are leaving the country at the moment. So then also you showed a picture of a lecture theater where the surgeon is operating and everybody is around watching it. I think we have got a lecture theater like that here in the anatomy department now. Michael might remember sitting there listening to the anatomy lectures and the dissections. And now it's a museum item. So if any one of you all want to go there and visit that and take a photograph for your lectures in the future, most certainly you're welcome. So Neil, as a token of appreciation, we would like to present you a memento, which is the history of surgery in Sri Lanka. Thank you.
Thank you very much indeed.